So I want to turn the virtual podium over to Kayla Sheridan. Very excited for this talk as well. So Kayla, feel free to take it away.
Thanks so much. Hi all. For those who don't know me, I'm Kayla. I'm an R2 in the program. Welcome to my living room. I use she, her pronouns, and I am going to talk to you today about Seattle area resources for patients experiencing homelessness, which is a talk that I have affectionately titled, How Can I Help? I have no financial disclosures. I do want to make a disclaimer, though, that I am in no way an expert on this topic. So I really appreciate any comments, questions, things like that you guys would like to add. I'll try to keep an eye on the chat, but feel free to unmute and shout things out as well. I want to give this talk because when I first started practicing medicine in Seattle, I felt like I had a really hard time getting a grip on what kinds of resources our homeless patients use in Seattle. And people would come to me saying that they stayed at XYZ place and I didn't really know what those things meant. So hopefully I can give you a little bit of that information. I'm hoping to give us sort of a whirlwind tour today of some of the resources available to patients who are experiencing homelessness in the area. So I'd like you to be able to recognize those resources, to be able to differentiate between types of survival and housing resources available here, and then apply those to some example cases. Before we dive in, a quick note on language. So how do we talk about our patients who are homeless? This is something that you can absolutely get in fights about on the internet if you are so inclined. Whether we say homeless people or people who are homeless or people who are experiencing or living with homelessness or people who are unhoused is controversial to a lot of folks. I don't think that there's really a right answer. I personally tend to try to use the combination of all of these terms and mostly try to mirror the language that my patients are using. I do think it's a good idea to use person first language, which is to say using homeless as an adjective and not as a noun.
Kayla, I want to
yeah.
flag you. It looks like your slides are not advancing. It's still stuck on just the
thank you. We only moved through 2 slides, so that's good to know. How about now?
Now you're on
objectives.
Yeah.
Great. Thank you. I appreciate it. Okay. So today we're going to review a number of different services for our patients who are homeless, but before we dig into specific resources, I'd like to talk a little bit about who is affected by homelessness in our area. We talk in general terms a lot about homelessness as an issue, both nationally and particularly here in the Seattle area. But people get a sense of the numbers that we're actually talking about by something that is run by the US Department of Housing and Urban Development that's called the Annual Point in Time Count, or PIT count, which is an annual physical counting of people who are living with homelessness in the US that occurs in late January of every year. As the name suggests, it's sort of a snapshot of one point in time annually of people living both sheltered and unsheltered. And it's organized by local continuums of care that are usually at the county level that get to decide if this is going to be a complete census count or if it's going to be sampling and then averages. And these COCs gather a bunch of demographic data as well. Unsurprisingly, this is a pretty challenging process and often a really imprecise one. And the PIT count is thought to actually dramatically underestimate the number of homeless people in the country. Actual numbers are thought to be maybe 2 to 3 times higher than the numbers that we have from this count. An important caveat as well is that all the data I'm going to share with you are pre-COVID-19 pandemic. It's obviously expected that COVID is going to have a significant impact on people who are vulnerable or marginally housed in our community. But it's going to be difficult to assess because the Seattle King County COC got a waiver from HUD to cancel the planned in-person count of unsheltered people in January of 2021. So we won't have any count of unsheltered folks until the coming year at the very least. So what do these numbers look like? Based on the last PIT count, about 580,000 people were reported as homeless on a single night in January of 2020 in the US, which is about 1.7 per 1,000 people. 39% of those folks were unsheltered, with the remainder in shelters or some sort of transitional housing. By comparison, in the Seattle-King County area, that number looks more like 5 per 1,000 people homeless in the same month, and nearly 50% of those were unsheltered. Seattle also ranks third highest among US cities for total number of homelessness and fourth highest for number of homeless per capita, which is why we talk about Seattle as a city with such a growing homelessness crisis. Now, you guys are all empathetic, excellent providers, so you're well aware that people affected by homelessness tend to be vulnerable in other ways as well. Both nationally and locally, a large portion of these populations experience severe mental illness and live with chronic substance use, and a not insubstantial portion of them also have a history of military service, live with HIV/AIDS, and have experienced domestic violence. There's a significant population of these folks that also represent what the HUD classifies as chronically homeless, which is a complicated definition, but generally means that they've been homeless for about 12 months at least. You all know this as well, but it really merits emphasizing. There's a really heavy intersection of housing insecurity with systemic racism, sexism, other structural biases that operate at an institutional level. One that I will point out is that nationally, Black and Native people are disproportionately affected by homelessness by about a 5-to-1 ratio per capita, as you can see here. And this is a trend that holds true at local levels as well. Folks that identify as trans and gender nonconforming are also overrepresented in the homeless population, but tend to be pretty dramatically underrepresented in shelter populations. So 60% of people living with homelessness nationally who identify as trans or gender nonconforming are unsheltered versus 40% of cisgender folks. And in Seattle, this is significantly more dramatic. So only 17% of trans or gender nonconforming folks who are homeless in Seattle are sheltered. This is also a population that has a high rate of lifetime trauma. So childhood trauma is extremely common in this population, as is violent trauma such as TBIs and other injuries. And a number of these folks have experienced domestic violence. Living with homelessness is also a recurrently traumatic experience in and of itself, which compounds this. And I really like this quote from a 1999 paper that I'll read to you because I think it's really impactful, which is, homelessness is a stress-filled, dehumanizing, dangerous circumstance in which individuals are at high risk of being witness to or victims of a wide range of violent events. Lack of housing isn't only psychologically traumatic, but also it has significant health impacts. People who experience homelessness are 3 to 6 more times likely to become ill, 4 times more likely to be hospitalized, and 3 to 4 times more likely to die at a younger age. The average life expectancy of homeless populations in the US, based on the mid-2000s study, is 42 to 52 years old, which is a number that was just staggering to me to read. Obviously, we could spend hours of academic half-day talks talking about how, as healthcare providers, we can deliver really good multidisciplinary, holistic healthcare to these populations to help mitigate some of these disparities. Today, as I mentioned, as a non-expert, I would just like to give an overview of the landscape of services that our homeless patients might make use of so that we can hopefully all have a better sense of the lay of the land when forming care plans for them. I will pause there for questions. Okay, well, let's start off with a case. So picture that you are on an internal medicine admitting service at Harborview, and you get called to evaluate a 52-year-old man in the emergency room for right lower extremity cellulitis. You do a brief chart review before you head down to the emergency room, and you see that he has a history of schizophrenia, hypertension, and diabetes. Looks like in the past he's been prescribed amlodipine, metformin, and risperidone. You go down, you talk with him, you get a little bit of a social history, and he tells you that he's been homeless for the last 7 years, more or less, and he's currently staying at St. Martin's. He tells you that he's not taking any medications and hasn't been taking any for quite some time. So let's talk a little bit about housing and specifically what are called emergency services, so shelters and day centers. Obviously, where someone stays really matters. Depending on whether someone is living sheltered or in transitional housing, if they're living in an encampment or otherwise on the street, people have different resources available to them that can either assist or complicate your medical plan. I do want to note that definitions of homelessness vary in breadth. So the HUD definition of homelessness, which the PIT count is based on actually excludes this bottom half of the list. So folks that are doubled up, which is staying with friends and family, and people who've been institutionalized in jails, hospitals, rehab facilities. So let's talk a little bit about where people stay. We're all familiar with people who are unsheltered, sleeping on the street, often in encampments. And I just want to emphasize the point that most of these encampments are unauthorized by the city of Seattle and thus are subject to frequently fairly traumatic sweeps as the city clears out encampments that they find most problematic. Until I started researching for this talk, I didn't actually realize that there are a number of formal authorized encampments in the Puget Sound area as well, which have a variety of eligibility fees that are required and a need for referral for an outreach team or not. These are usually self-managed camps that require shared participation in serving the camp and typically require what's called clean and sober living. This map on the right is a map of authorized Puget Sound encampment sites as of September of 2020, although I will note that encampments tend to move every few months. Now, moving on to shelters, which is where a lot of our patients will spend some portion of their nights. Shelters offer a wide variety of resources. I pulled a list of a number of shelters in town here just so that you can see some name recognition, and then we'll focus on a few specifically in the next slides. This is absolutely not an exhaustive list. Many of these are what are called enhanced shelters. So not just a place to sleep, but places that might offer case management services, sometimes medical care, sometimes hygiene or food services. So it's really important to understand what resources are available to patients at the shelter that they're staying at. I will also note that some of these sites do have a religious affiliation, and there are a few that also require that clean and sober living, although not as many. And these sites range from being places that folks walk into, they line up at night to try to get a spot, or places that are referral required and people can return night after night to the same bed that they have reserved. So let's talk about the Downtown Emergency Services Shelter, which is one of the biggest shelter systems in town. And all of you in your time practicing medicine in Seattle will see patients who stay at a DESC site. They have a mission to end homelessness for the most vulnerable people, which they consider folks that have mental illnesses, substance use, or other chronic illnesses. DESC has a bunch of shelter sites around town. These are their three largest, so their main shelter, which serves over 200 clients a night, and then the smaller Queen Anne and Navigation Center sites. All three of these sites offer meals, hygiene services, on-site case management. The main shelter downtown also offers a lot of other pretty cool wraparound care. So they have on-site medical care, they have on-site mental health counseling and chemical dependency counseling. I will note that the DESC shelter sites downtown are actually temporarily closed during the COVID-19 pandemic to allow for social distancing. So clients have all been relocated to either a temporary shelter at the Red Lion in Renton or to the Seattle Center Exhibition Hall, but they're still serving the same number of clients. Catholic Community Services is also a large shelter and housing network in town. They have a number of high volume shelters in the Seattle area, particularly St. Martin's, which serves over 200 men over 40 years old. They also offer meals, hygiene facilities, case management on-site, drug and alcohol counseling, and they have nursing on-site multiple days a week. They also have a pretty cool day respite program, which serves folks that are ill or injured and may require up to 24-hour assistance with medical care, which they provide, as well as transportation to medical appointments. St. Martin's is open during the pandemic, but they've moved some of their higher risk or elderly clients to other sites. The Union Gospel Mission is another large volume men's shelter in Seattle. They provide overnight shelter to men, 3 meals a day. They have hygiene facilities, but not quite as many other wraparound services. They do, however, also have an extended care floor upstairs in their same facility that offers extended post-hospital recovery care. Lots of other shelters in town. I won't go into specifics of all of these, but I do think it's important that everyone is aware that there are often specific housing resources available for folks, not only by gender, but also by ethnicity and background, families with children, sex workers, history of military service, history of domestic violence. So this is something that it's worth asking patients about and having social work help ask about. Aside from places to sleep at night, survival services also encompass places where people can spend time during the day and make use of some of the services that are really hard to access when you are not housed, like laundry, mail, computers, storage, things like that. Day centers offer these services and often also provide some degree of case management and sometimes medical services, depending on the site. They also provide just a space for recreation and social interaction for folks. All of the shelter sites I discussed on the past slides offer at least some daytime services, and Catholic Community Services and DESC both have quite a lot of daytime support services. I'll also mention Angelines here, which has a day center that serves over 200 women a day with embedded nursing and case manager care. Just to give you a better sense of what range of services these places offer, this is one example. The Downtown Compass Center is a pretty typical example of a day center. They offer mail and banking, hygiene services, and housing navigation services, and have an embedded nurse multiple days a week. By contrast, the Bread of Life mission, which is another downtown site, offers food, mail, storage, clothing, etc., but they don't have as many sort of social services, support services available on a daily basis. So I'm hoping that I'm making abundantly clear that homeless has a wide range of definitions for folks. And there are a lot of services available to people depending on where they're staying. Something that is really helpful is to make sure that we're asking and documenting the specifics of where people stay. So that can be asking where they slept last night, where they typically stay, and how long they've been there and are planning to be there. It's also really helpful to ask what resources are available at their site if they know, and if they don't, social work can help you figure this out as well. So is there a nurse that comes by or a provider, and how often? Is day rest or respite an option? And do they have case management? Do they have an assigned case manager that they work with? It's also really helpful to get specific contact information for these folks depending on where they stay. Lots of people don't have a phone, but if they do, getting a number and seeing if they have minutes available is helpful. If not, seeing if they can get phone calls where they're staying is really helpful. And if they're not available, if someone can leave a message there, and then figuring out if they have mail service somewhere, if they can get letters. Regardless of the situation, trying to get an emergency contact, someone you can reach if you can't reach them, is helpful. And then documenting these things. So putting this on the problem list, letting folks who care for the patient in the future know how to get a hold of them is really helpful. And if they have a case manager, a psych provider, things like that, it's really helpful to list that in their care teams in Epic as well. So returning to case one, you admit your patient to medicine E overnight and start them on IV antibiotics. And when you round post a call, they're looking better, they're afebrile, symptoms are improving. You do notice that the patient is responding to some internal stimuli, but otherwise is looking pretty well. Overnight, you had the chance to do a little bit more chart review, and you noticed that this patient has frequent emergency room presentations for primary care type problems, but generally has missed any outpatient appointment that they've had scheduled for the last number of years, and really has a lot of difficulty adhering to meds, it seems like, per chart review. So I'd like to use this as a time to talk about more long-term housing options that can provide stability, particularly for more vulnerable patients. You might be getting the sense that there are a wide range of options, and that is true for this as well. So transitional housing and supportive housing are the two big groups that housing options fall under. Transitional housing tends to be short-term, temporary housing ranging from weeks up to years. It's really intended to act as a bridge for homeless clients to find long-term housing. Options in Seattle vary significantly in terms of whether referral is a requirement, how much rent is required to be paid, and whether sobriety is a requisite for living there. Some of these sites specifically serve folks who are recovering from substance use disorder, and so do require that clean and sober living. Supportive housing, by contrast, operates from what's called a housing first model. So this is an approach that prioritizes providing permanent housing as a foundation for patients to then build more stability, improve their health and well-being. And it thus doesn't mandate any kind of participation in social services, doesn't require any kind of behavioral compliance. These are permanent housing sites that also offer voluntary support services and are generally intended to address the needs of folks who are more chronically homeless and particularly vulnerable. Both of these types of housing exist in a number of forms in the area, from dispersed apartments in otherwise regular housing to consolidated housing sites. These sorts of housing in King County are accessed through what is called coordinated entry for all, which is a centralized process where clients are assessed and then they're triaged based on vulnerability before they're referred to a type of housing. This is worth knowing because it's accessed through what are called regional access points, which are walk-in sites that have somewhat limited hours throughout the King County area. So it's not always super straightforward to get enrolled in this process. I will also note that CEA serves a broader range of clients than the HUD definition of homelessness. So notably, this is a process that includes folks who are institutionalized for a short time in a hospital, jail, anywhere like that, if they were previously living homeless. Still does not include folks who are doubled up though, or folks who are institutionalized long term. So talking about transitional housing just for a brief moment, there are a really wide range of transitional housing options available in Seattle, and I'm not going to provide you with any kind of extensive list. I mostly just want you to have a sense that they exist in a variety of forms in the area, and that they vary really significantly depending on the location, but all are time limited in some way. Some of the large organizations I already mentioned, including Encompass and Catholic Community Services, have transitional housing programs, but there are myriad other options in our area. Similarly, permanent supportive housing has a wide range, and there are a lot of organizations in the area that provide supportive housing, but I wanted to highlight these groups specifically because you'll likely interact with patients who stay at some of these sites in your clinical work. You'll see some names here that are probably becoming familiar to you if they're not already. Catholic Community Services offers a really large number of permanent low-income housing sites, and some of them, which I've listed here, are considered supportive housing, which are accessed through the CEA and have some limited support services like case management. Compass Housing Alliance also has a few supportive housing sites. Plymouth Housing is a really interesting Seattle organization that focuses exclusively on providing permanent supportive housing at this pretty long list of sites. All of these sites have housing case managers that are paired with clients to help them access needed services. A few of these sites that I'll mention specifically also have more extensive support. The Langdon and Ann Simons building has an on-site neighbor care nurse present. Pat Williams' apartment has daily focused substance use treatment. And Plymouth at First Hill is definitely worth mentioning because they have on-site medical and behavioral health care by Harborview staff. So we know folks that provide care at these places. And then last, but by no means least, DESC also has a strong and it seems like ever-growing list of supportive housing sites. All of these sites offer a pretty extensive array of services. They all have med management at the front desk. They offer meals. They have 24/7 support staff. They have case management on site and mental health care on site. A number of these sites I'd like to mention specifically as well because they have really specific and even more extensive care. The 1811 is a really cool site that has chronic alcohol use support specifically, and those are the clients that they tend to recruit to this site. They offer pretty in-depth substance use disorder services, and actually that includes managed alcohol at the front desk to help folks avoid withdrawal if they're still drinking. They also have on-site provider care multiple days a week. The Estelle also has on-site nursing and MD care, and they actually have a partnership with Harborview to reserve 15 of their rooms for patients that have high healthcare needs that would typically not be able to be cared for in a residential setting. Hobson Place is an interesting site that's in process right now. It's intended to ultimately serve clients that have disabilities and has ultimately the plan for an embedded Harborview clinic, although that isn't up and running yet. The Lion Building has on-site nursing, and it was initially established by AIDS Housing of Washington and still serves a lot of clients that have HIV or AIDS. The Morrison Hotel is DESC's largest permanent supportive housing site with 190 apartments and has an embedded neighbor care primary care clinic in the building. And then finally, the Union Hotel has on-site nursing and provider care. So you mentioned to social work on dispo rounds that this patient seems pretty vulnerable and would benefit from referral to more structured housing, particularly permanent supportive housing. So they help him set up a CEA assessment on discharge. You update his problem list with his current contact and housing information before discharge. I will pause here for some questions because I think I'm seeing some things come in the chat. Oh, well, I see lots of comments that my slides weren't working, so thank you all. I appreciate that. Um, and then Hannah notes that many of the DESC providers, including nurses and circulating ARNPs, can be reached on Epic for super easy care coordination, and this is very true. And then the DESC sites have UW providers who know patients really well. And this is something that is really cool if you know someone is staying at one of these sites while you're in the hospital or in clinic. These providers are often really happy to work with you to help figure out a dispo plan or a care plan that is going to be successful in the housing situation that your patients are leaving to. So thank you guys for those comments. Other questions? Okay. Let us move on to a second case. So this is a 56-year-old woman who presents to your clinic to establish care, and she tells you that she's got a rash that she's concerned about. Started maybe a week or so ago. It's located around her neck, her back, her chest, and her waist, and it's been so itchy that she's not been able to sleep. You get a little bit more of a social history from her. She tells you that she's been staying at Angelines, but she spends most days walking around the city, and she did get some new clothes a few days ago. On physical exam, she has erythematous papules around her neck and upper extremities, as well as her waist, with some overlying excoriations that spare her hands and feet. You do also notice that the bilateral plantar aspects of her feet have some flaking skin and a little bit of redness. So this brings me to a topic that we talked about a little bit already, but that merits its own conversation, which is hygiene services in our area. Access to shower and laundry facilities is understandably pretty limited for a lot of our homeless patients. And because of this, as well as congregate living situations and limited clothing availability, infestation is really common with these folks. Patients experiencing homelessness also tend to spend a lot of time outdoors on their feet, which in Seattle means in the rain for 9 months out of 12. And it's pretty difficult often for folks to stay dry. So tinea pedis is also a common problem. So where can patients access hygiene services? As I mentioned, this is a common service at a lot of day centers and shelters, although it can be pretty limited in timing in a way that can make it difficult to coordinate the multi-step tasks needed to treat infestation. Some of the organizations I talked about already, such as the Union Gospel Mission, also have mobile hygiene services that send vans out to provide this service to clients where they're at. Urban Rest Stop is an organization that also offers laundry and shower services at multiple sites in town, which you'll see here on the right. And Seattle Parks and Rec also has free shower services at many city parks. I will also note that during the COVID-19 pandemic, the city of Seattle also funded a number of hygiene service sites that are theoretically still up and running. There's an interactive map that I've screen capped here that's available on the seattle.gov website. So carrying on with our case, you tell your patient that she has body lice and you discuss with her washing all of her clothes and linens and drying them on high heat. You coordinate with social work to help her find some places that she can go to do this laundry, and you give her a set of clean clothes to put on while she's doing this wash. You also treat her tinea pedis with clotrimazole and give her some clean, dry socks. Throughout the visit, your patient's a little bit guarded, but she agrees to a lab draw. And so you plan to call a friend's phone with some lab results and thank her for coming in. You set up a return appointment for a couple of weeks to continue assessing for chronic issues. Your patient returns to clinic for follow-up in a couple of weeks, and her interval labs have shown hemoglobin A1C of 10. She tells you that her rash has gone away with the treatment and she's thrilled about that. When you take a little bit more of a detailed review of systems, she does mention that she's maybe been a little bit more thirsty and urinating more often than usual for the last few weeks. You also get a finger stick glucose in clinic and her sugar is 230. As you start to think about next steps for management of this patient's newly diagnosed diabetes, you start to think about factors that will affect your plan, including your patient's access to nutritious food. So let's talk just briefly about food services in Seattle. So unsurprisingly, there are also really high rates of food insecurity among patients experiencing homelessness. As you've probably gotten a sense, there are many shelters, day centers, and other organizations that provide food services to clients, but it can be pretty difficult to get 3 meals a day for folks. And it certainly is very difficult to follow a restrictive diet, such as an AHA or ADA compliant one. because patients are also often not sure when exactly their next meal will be or what it will contain, it can be challenging to use medications that cause hypoglycemia as well. So a way that you can start to help with this is just by assessing your patient's access to food and documenting that as well. So asking folks how many meals a day they eat and where they tend to eat, and then which of those meals tends to be their largest. Is breakfast coffee and a pastry that they get somewhere, but at dinner time they usually have something more substantial. Um, you can, of course, work then with your clinic social worker and nutritionist to help kind of guide treatment plans based on these things. Here are just a list of many types of places that folks can access food resources in Seattle. Your social worker at whatever site you're working at can be more helpful with things that are specifically in the area that can help out with your patients. But I'll note that beyond shelters and day centers and supportive housing sites, there are also food pantries in town and food banks throughout Seattle that offer food services to low-income folks. And then, of course, SNAP food stamps benefits are also something that some people find helpful. So you take a little bit more of a history, and your patient notes that she usually eats a couple of meals a day and reliably at least has dinner most days. She is a little bit reluctant to use pre-meal insulin because she's nervous about carrying around syringes. So you start metformin and you agree to continue talking about insulin and think about maybe just starting a basal insulin alone in the future. You schedule her with close follow-up to come back and talk more. I'll pause there for a moment. Questions? All right. Let us then move on to our third and final case. So this is a 28-year-old man who comes to clinic as a drop-in patient for a thigh abscess. He denies any past medical history. He doesn't take any medications. He tells you that he's actively using injection heroin and mostly muscles into his thighs. And he says that he's staying at the Union Gospel Mission. Oh, let's see what popped up in the chat. Yes, so insulin, I always think about times for refrigeration for the medication, Oyinka says, and that's something that is really important to consider as well. And some places can offer storage of medications, like some of these supportive housing sites for folks that need refrigerated medications. That's a little bit harder to access at a lot of our shelter sites. So if you're thinking about using insulin and you're thinking about prescribing patients more than a month at a time, it's worth thinking about whether they can access refrigeration or not. That's a really good point. All right, moving on with our case. On physical exam, you note that your patient has extensive scarring and multiple small open abscesses at various stages of healing on both of his thighs. You do also note one closed abscess that's fluctuant and tender and seems like it maybe needs incision and drainage. So let's talk a little bit about substance use services in the area. I'm not going to belabor this point because all of you heard a great deal about harm reduction for people who use drugs at Academic Half Day 2 weeks ago. So I actually consolidated these slides this week. But I just want to remind you that substance use is really common among people experiencing homelessness, and that harm reduction and non-judgmental care is really helpful for them. I just have this here to remind you that needle exchange sites exist at many locations close to some of our supportive housing and shelter sites in Seattle. And that also a lot of these needle exchange sites are places that folks can get Narcan. I also just want to mention quickly that methadone treatment sites in Seattle are spread pretty widely throughout the Seattle-King County area, but that often are a little bit hard for folks to access because there aren't very many of these really close in to the downtown area. Let's see, Sandeep says the downtown Robert Cluess Center also has a walk-in dental clinic on weekday afternoons, the same time as needle exchange occurs. They do, and they have a walk-in medical clinic, I think every day. I will have to check on that, where folks can come in and get either sort of drop-in medical care or get plugged in with primary care. Can you touch on the challenges of finding housing for folks who need methadone for opioid use treatment? Yeah, that's a really good question. So I think many of these housing sites, supportive housing sites that I talked about, are places that take care of a lot of folks who are actively using drugs or that are on medication assisted therapy of various kinds. I think that folks who struggle to get to methadone sites are often the kinds of folks that are also needing more of these support of these kinds of housing sites. I'm not sure, and I can try to find out for you, Oyenka, if you'd like, if there are any sorts of transportation options available for patients that are having trouble accessing these sites. But for most of these housing sites, using either opioids of various kinds or being on medication assisted therapy for opioid use disorder is not a barrier. Does that address your question at all?
Yeah, it does. Thank you, Kayla.
Sure.
I mentioned it just because I had a lady who we were having a really hard time getting into more, I guess, less supportive type, more stable housing. And
Mhm.
for her case, the barrier was the fact that they didn't accept patients who use methadone. They accepted Suboxone. So I wasn't sure if that was through a lot of other sites or that was kind of just a unique situation.
Yeah, and I think that other transitional housing sites, as I mentioned, are a little bit more limited in the clients that they will accept in a lot of ways. So traditional sort of permanent supportive housing accepts all comers and says, you know, we think that your substance use is something that makes you vulnerable and in more of need of housing. But a number of other low income or transitional housing situations require patients to be abstinent from substances. And I could imagine that that could at times include methadone. Okay. Um, so returning to our case, you perform a bedside IND of your patient's abscess and you provide some harm reduction counseling. You refer him to a needle exchange site for some clean supplies. Um, you do note that the patient's pretty guarded throughout your encounter and really isn't making good eye contact or seeming to want to engage with you very much. But you suggest that he schedule a visit to come in to return and establish care with your clinic. He's pretty reluctant and tells you that he doesn't really see doctors much. So here I would like to pause and just talk for a brief moment about what accessing healthcare can be like for these patients. Um, you guys know this really well, but I don't think it's something that you can overemphasize, which is that patients who live with homelessness are often traumatized over and over again by interacting with institutions and societal structures that are really not built for them. And this can really include frequent trauma at the hands of the medical system. Patients who have been homeless or are currently homeless often feel pretty unwelcome and extremely stigmatized in healthcare settings, and that can make it really hard for them to want to access care, which is understandable. Obviously, this is a huge problem that none of us is going to single-handedly fix, but I think on an interpersonal level, we can do our best to be open and welcoming and to try to build rapport with patients that tend to feel excluded by our system. That can be as easy as making sure to tell patients that we're glad that they came into clinic, to thank them for coming in, telling them that it's good to see them again, or that we're looking forward to having them come back. So wrapping up this final case, your patient actually comes back to clinic in a couple of weeks for a new patient visit, and you tell him, I am so glad that you came in today. Thank you for coming in. You ask how you can help today. So that wraps up our final case. Before we finish, I do want to leave you all with some really helpful resources to find more information on these kinds of services, both for your patients and for your own learning if you come across a service that you don't know and you haven't heard of before. The first of these is this very cool little purple book in its most recent iteration, which is 2019. This is the Emerald City Resource Guide, and it is a list of resources available to patients in Seattle that range from crisis services, mental health services, encampments, shelters, other housing resources, food resources, substance use resources, and medical resources. The website for this is actually particularly useful. It's at this URL listed here, and it's an online version of this that lets folks actually search by gender identity, other identity groups, and then by the specific sorts of resources they're looking for. Thank you, Dr. Cho, for putting that in the chat. Another resource that can be helpful for folks is Crisis Connections, which actually runs the King County 211 line, as well as a number of other resource lines in the area. They also put out an emergency services brochure that is updated, it seems like, fairly frequently. This one is up to date as of 2021. It's available at this website. And it has many pages of similar sorts of resources of places that people can stay and other kinds of help. Um, I will note also before we wrap up here that there have been a pretty wide range of responses in the city of Seattle to the COVID-19 pandemic. Some shelters, as I talked about, have moved patrons to entirely new temporary locations. Some are operated at limited capacity in their usual sites. Some are operating at their normal capacity and hours. And I actually, even doing research for this, ran across a couple of shelters that are requiring proof of a negative COVID-19 test before they will allow clients to stay, which seems awfully restrictive to me, but I did not get to make that choice. Overall, these services are operating with pretty limited capacity right now, and there have been outbreaks of COVID-19 at some housing locations. So it is really helpful to know when you're arranging follow-up or discharge plans for your patients, what kind of housing situation they're living in. If a patient has COVID-type symptoms, are they somewhere where they can go back to their temporary or permanent housing site and self-isolate, or are they living somewhere that's a semi-congregate setting where they would need to be elsewhere in order to be effectively isolated? I will also note that a lot of other ancillary services that folks who are unhoused access, like public libraries and things like that, are also closed during the pandemic. So let us summarize briefly. Reviewing our objectives, I'm hoping that you guys feel a little bit more comfortable recognizing the sorts of resources available to our patients who are living homeless in the area and differentiating between types of survival and housing resources that are serving these folks. And hopefully you found it helpful to apply these to some example cases. With that, thank you so much for your time and attention. I do want to extend infinite thanks to Don Taniguchi at the Third Ave Clinic, from whom I unabashedly borrowed some language and a lot of the structure of this talk. And then thank you to the wonderful doctors Dunlap, Crivero, and Wykowski for being sounding boards as I put this talk together. What questions have you for me? Let's see, in the chat. Do you have guidance about how to help unhoused individuals get vaccinated against COVID-19? That is an excellent question that I don't have a good answer for you. I can try to find out and send info on that out if I find anything. As far as I know, I don't know of any specific resources that are trying to get our homeless population vaccinated in the area as a concerted effort, but if it doesn't exist, it ought to. So if I find anything out about that, I can send an email out.
Kayla, it does exist. This is Hannah. I'm one of the Pioneer Square Clinic.
Oh, beautiful.
So there's some mobile van efforts that are going on. Our clinic is very knowledgeable and helpful. If anyone wants some resources, can reach out to our front desk. Also, Naomi Scheich, who is one of the prior chief residents and currently one of our attendings, is really involved in that effort. So they're going around all over the place. There's also a lot of I'm not sure who it is, but there's programs that are stopping by a lot of the supportive housing and just like vaccinating everyone.
Very cool. Thank you. That is extremely helpful. Catherine also says the public health outreach street medicine team hopes to have vaccines soon as well. Cool, because they are very good at that and do great work. Awesome. Other questions, guys?
Hey, Kayla.
Yeah.
Just
hey.
plug for the Bailey Boucher house as well. There's a
Yes.
homeless shelter. So you have to be HIV positive to use those services, but it does fill a niche that is lacking for a lot of our LGBTQ community. Again, you have to be HIV positive to use that shelter. So there are lots of people that fall out of that category, but it's a great thing, and they actually do some direct observed therapy for antiretrovirals, et cetera, as well.
Thank you, Julie. Yes, that is an important one to mention. All right. Well, thank you guys so much for engaging and letting me talk at you. I will stop sharing my screen here.